Welcome, and thank you for joining us to learn more about nutrition symptom management. My name is Colleen Gill, and I am a registered dietitian and certified specialist in oncology at the Anschutz Cancer Center at the University of Colorado. Today I'll be speaking with you on behalf of the Association of Community Cancer Centers, sharing some strategies that help cancer patients manage problems that otherwise result in excessive loss of weight and strength and compromise their nutrition status. Most, but not all, cancers are associated with weight loss. In fact, overweight patients often view this as the one positive outcome of their diagnosis and are surprised to learn that an unplanned loss of just 5% is actually associated with worse outcomes. Happily, we can prevent the negative impact on survival time, performance status, and quality of life by helping them maintain their weight. Unfortunately, tumors and their treatments often leave cancer patients with significant difficulties in eating. Most will complain of lack of appetite, making them forget to eat, taste changes, leaving them unmotivated to finish, and early satiety, limiting them to less than half their normal volumes at mealtimes. These issues are problematic enough, but any additional obstacles must also be dealt with if we expect our patients to be able to follow our recommendations. While we can't eliminate these problems entirely, we can help patients work around them by discussing 4 critical concepts. These include the need to structure regular intake, include fluids with calories that also address dehydration, adjust their expectations from food, and use supportive medications appropriately. We can first help patients recognize that while they can't eat much at one time, they can maintain their weight by eating these small volumes more often. Patients and their family members are usually quite concerned about the small portions of food that the patient is eating and will be receptive to strategies to help them deliver the missing calories and avoid rapid weight loss. Using the example of young children with small stomachs that must be filled frequently, they can see the benefit of a preschool schedule, eating every 2 to 3 hours. Of course, the difference is that our patients don't feel the hunger that triggers children to eat, but by setting cell phone alarms as reminders, they can avoid missing these critical opportunities to take in needed calories. They will all admit that they have lost the flexibility to skip meals and make up for it later with a big dinner. Since eating anything is difficult, making each bite count is simply common sense. Beginning with foods they have liked in the past, we can help them find ways to increase calories. Adding cheese as they scramble an egg can add 100 calories while softening the texture as well. And including avocado in salads or sandwiches, topping an English muffin with peanut butter, or throwing a handful of walnuts on oatmeal all concentrate the calories they gain from each bite. Fluids are especially well tolerated and can deliver calories while limiting the risk of dehydration. Fluids empty out of the stomach more rapidly than solids, creating less distension and discomfort. So finding fluids with calories helps patients meet both their fluid and their calorie goals. Be sure to offer samples and information about where they can buy these supplements once they identify a few that they like. Cost can certainly be an obstacle for indigent patients, so many centers will use donated funds to buy supplements through lower contracted prices. Medicaid patients can be referred to home health care companies since this is a covered benefit in many states. Patients must know the signs of dehydration and understand that it will aggravate every symptom that they experience. I explained that cells work best as plumped grapes rather than dried raisins, something that they'll notice when a plant given up for dead recovers within a day of watering. We should clarify their goal of clear, light, lemonade-colored urine at normal volumes. Darker urine approaching apple juice in color means that their kidneys are working overtime to save fluid. Of course, many patients are not really natural drinkers, but we can help them build this new habit by tying it to a current activity. Try having them place their drink next to their chair while watching television, drinking a couple ounces at every commercial, or alternatively with every few pages they read or minutes they spend on their computer. We have to remind them that we cannot manage their nausea, constipation, pain, or fatigue without adequate fluids. If patients aren't able to drink enough to keep up with their losses, scheduling routine IV fluids should be strongly encouraged. After we discuss scheduling and fluids, we can work with patients to adjust their expectations from food using a medication analogy. Patients have to understand that they cannot wait to eat until food sounds good again. They don't expect taking pills to be fun, and unfortunately, they can't expect food to be fun at the moment either. 3 o'clock should trigger patients to select a dose of food, hungry or not. We find that developing a list of options for meals and snacks can limit the stress of coming up with an idea when it's time to eat. Their list should include the extras that increase calories, since including cheese, mayonnaise, whipped cream, or extra butter won't be automatic if they have historically avoided these extras. Including some ethnic foods will add flavor, getting past damaged taste buds. Moist foods and sauces help spread taste around the mouth and can limit the disconcerting feeling of texture without taste, which some patients refer to as chewing cardboard. Having these options improves variety and prevents the inevitable burnout when one food is used exclusively. Patients should list some easier choices for times when energy or appetite are especially limited, but choosing nothing cannot be an option. If Jell-O is the only choice that's tolerable, 90 calories is better than 0. Involving the patient in setting timers and selecting foods leaves them in charge. This limits the control battles over eating that can develop. These are conflicts that simply never end well. Even subtle pressure to eat can make us rebel, triggering childhood memories of being made to eat something we didn't want. Talk to family members about the many ways they can support the patient, helping them develop the list of options, shopping for them, and even preparing the meals they request. They cannot make the patient eat, and they should be told that we don't hold them accountable for that. The patient must take on that responsibility, understanding the consequences of their weight loss. Pain, nausea, constipation, or diarrhea can certainly derail a patient's best efforts, so educating them about medications is critical. Medication reconciliation can actually be quite enlightening and an opportunity to reinforce your prior education. Many patients either do not understand how medications should be used or may hesitate to take them for a variety of reasons. Those that are written as PRN can be especially problematic since prevention will always trump trying to catch up with symptoms. I offer no brownie points to stoic patients who are limiting needed medications. Remember to review over-the-counter medications as well, since patients will often avoid taking anything that hasn't been okayed by their oncology team. These will include the use of Senna or Miralax and stool softeners for constipation or Imodium for diarrhea. Be sure to discuss gradually increasing these to the effective dose, while clarifying the doses that are typically used. Package instructions often limit consumers to half the totals we use routinely in the oncology setting. Whenever possible, offer medications that cover multiple symptoms. For example, mirtazapine or Remeron can help increase appetite while improving mood and sleep, so we'll typically try this before moving to Megace ES. For anxious patients on lorazepam, timing it as small doses prior to meals may decrease their anticipatory nausea as well. And most importantly, remind patients that there are always additional options. Encourage them to let you know when what you originally offered isn't working. Finally, we realize nurses are busy and won't have time to provide this nutrition education consistently. Nutrition issues are best covered with a good screening program and referral to a dietitian that works in your center. Where these steps have been put in place, cancer centers have been surprised to learn the number of patients with unidentified and undersupported nutrition needs. A dietitian with certification as an oncology specialist, designated as a CSO, will have the skills to help patients and to educate the staff working with them. I hope I've given you a few strategies that will help you address some of the difficulties your patients experience with eating. You can find more help within the resources listed at the end of this video. Thanks again for joining us to learn more about nutrition symptom management.